Welcome back to the American College of Surgeons Bulletin Brief from the Front Lines, Surgeons' Voices. With me today is the chair of the American College of Surgeons Committee on Trauma, Dr. Eileen Bulger, who is in Seattle, Washington at University of Washington. Welcome, Eileen.
Thank you. It's nice to be here.
Appreciate your time today, and certainly appreciate your time with the Committee on Trauma, a very formidable task of a very important group, which has been around for quite a long time. But realizing that the majority of our viewers may not be trauma surgeons, perhaps you could tell us a little bit about the history of the COT.
Sure. Yeah. The Committee on Trauma is actually approaching its 100th anniversary next year. So it was founded in 1922 by Dr. Charles Scudder as the Committee on Fractures. And the objectives at that time were really to standardize and improve the care of fractures around the United States and Canada. And it's really grown over the last 99 years to be a worldwide organization focused on all aspects of the care of the injured patient and injury prevention. We run a number of programs. We have a comprehensive suite of educational materials for training in trauma care. And we have set standards and now verified trauma centers around the country for optimal trauma care.
Thanks very much for those insights and congratulations on the centenary of this important group. You mentioned around the country, how many centers are COT accredited?
Yeah, so there are 565 verified trauma centers in the United States. And we also run a trauma quality improvement program that collects data and provides risk-adjusted benchmarking for outcomes. And we have over 800 hospitals enrolled in that program.
That's very impressive. Congrats again. So you mentioned in the country. What about out of the country? What are some of the activities in which the COT engages outside of the borders of the U.S.?
Yeah, we do support trauma system development internationally as well. But really what we're most known for is for education. And that's really on the back of the Advanced Trauma Life Support Program, which began in the 1980s and has really become a worldwide program which is taught in over 80 countries in the world and provides a common language for the care of the injured patient.
And could you give us some idea of the scope of countries in which those education programs are delivered?
Yeah, we have 4 international regions and really covers the footprint of the world, all of Europe, much of Australasia, and all of Latin America.
Very impressive indeed. One of the main impacts of COVID was on intensive care, which of course also impacts trauma care and emergency rooms, all the things that are within the purview of you and your colleagues in COT. So if you'd be so kind, tell us what happened. How was the COT engaged? How were trauma surgeons engaged in the early days of COVID and through the rest of the pandemic?
Yeah, I think there's 2 main ways. One is obviously in clinical care, because most trauma surgeons are certified in surgical critical care and therefore are intensivists. And so we're pulled in early to participate and to help offload the clinical care for critical care patients. But in addition to that, I think a critical role for the COT and for trauma surgeons is in looking at the regional coordination of care, because we know from developing trauma systems that if you regionalize care and you can distribute patients, particularly in a mass casualty event, to a wider number of hospitals, then you can improve outcome. And so the trauma systems have built emergency response systems for large events, hurricanes, earthquakes, things like that were stood up for COVID as well and have proven beneficial in areas where they're well developed. It's the concept of the Regional Medical Operations Center, and we've been working hard to advance that concept during the pandemic and hopefully in the post-pandemic period as well.
The surgeons who participate in COT are obviously, as you just said, maybe thrown right into the front line as intensivists, as well as other parts of the healthcare system because of their knowledge and practice. That potentially predisposes to burnout and as well as exposure to the virus itself. The ACS certainly has a lot of programs for wellness. Does the COT have separate programs to help mitigate against some of those problems that may be encountered caring for COVID patients?
I think we certainly benefit and rely on the larger ACS for a lot of those efforts. Within the trauma community, of course, it's a close-knit community. And so we have had, sort of WhatsApp chat groups and things like that, where people can share knowledge as things were evolving. And I think that was very beneficial around the world. And we also participated in a number of large international conferences to try to share what we were learning as the pandemic went on.
So let's stay on that theme for a moment and think about learning. So what are some of the lessons learned? You mentioned you already, antecedent to the pandemic, had some implementation strategies and pathways for earthquakes and hurricanes and floods and mass casualty events. But what are some of the lessons learned from the pandemic?
Yeah, I think in that area, we've learned a lot because while we've had those in place, they're highly variable around the United States. And in some places, there are pre-existing relationships between the hospital systems that allow them to work collaboratively together in that sort of a setting. And when those pre-exist, then we were able to stand up a regional structure very easily, which allowed us to distribute patients, to collect data from all the hospitals, to understand what was happening in real time. But in other parts of the country, those relationships did not exist, and it was much more fragmented and much harder to organize the response. And so that's one of the things that we're working on now, as people start to look at sort of the after action reports from how we did as a country in responding to this event. How can we better organize ourselves nationally so that we don't run into that circumstance again, where some parts of the country can handle that regional coordination better than others?
And on the theme of coordination, you have surgeons like me who are fairly remote or tremendously remote from surgical critical care. And yet when hospitals have surges, they're trying to lay on extra intensive care capacity, using ventilators that are normally in storage or rooms that are normally not ICU, which of course requires the training of non-trauma critical care surgeons. So do you have a particular program that's been developed as a kind of crash course for how those of us not in trauma critical care can help you and your colleagues during the next time we have such a pandemic?
Yeah, we do know in many parts of the country, because the trauma surgeons were called into the ICU, that many other surgeons had to backfill covering trauma, which is not something that they have done in many years. And so as one of the things we did from the COT is provide some just-in-time education through our ASSET course, which is a surgical skills course, and from our ATLS modules as well, for surgeons who were sort of pressed into service caring for trauma patients. And we hope that was a useful addition for them.
In the last few minutes, could you share with us which of all of these things that have been developed you think is going to last going forward, that you're going to keep on the front burner and not, let's say, put on a shelf till the next time, but will be incorporated into standard practice?
Yeah, I probably have talked about it too much, but I think that the regional coordination of our response is so critical. And I'm hopeful that that will really move forward. We've been working with the Office of the Assistant Secretary for Preparedness and Response on thinking about how we can really make that a nationwide program, because I think that that will make us better prepared, not only if we have another pandemic, but for other disasters as well as a nation, if we can put some infrastructure in place now and resource it appropriately.
Well, resources and regional are two words you just mentioned, which of course brings to mind that the last issue I'd like to cover, and that's healthcare disparities, because it's certainly been written about in many aspects, including COVID-19, including trauma. Perhaps you could share some of your thoughts about some of the findings of healthcare disparities that came out as a direct result of COVID-19.
Yeah, I think one of the things that we saw during the pandemic in our trauma centers is early on, obviously, when the first lockdowns occurred, the trauma volumes went down substantially because people weren't driving. But what we saw, especially in our major cities, was that the penetrating trauma did not decrease and has actually increased over time. So we were worried a lot about the social determinants of health in our patient population and the impact that this pandemic has had on them from an employment perspective, from a housing perspective, and all of those things feed into an increased risk for injury. And so we are very much focused on thinking about how we can better address the social determinants of health, because we do think that that will impact the rates of injury as well.
Thank you. Very, very important area that we need to address. I'd like to give you the opportunity to share any additional thoughts which you may have with our listeners and viewers today.
I think it's been a challenging year. I hope that we will learn something from that, that will make us stronger moving forward. And I think we owe a debt of gratitude to all of the healthcare providers who've really stood up and dealt with the challenge of this year and sacrificed their time, their energy to make an impact. And our job now is to learn from that and to think about how we support each other and make sure we focus on avoiding burnout and thriving as a profession.
Well, I think we certainly will thrive with you at the helm of the COT. It's clear. I've had the pleasure of hearing your reports on many occasions. The work you're doing is impressive, it's formidable, and it's greatly appreciated. So thanks for all that you do all year round with COT, and thanks for your time and reflections today.
Well, thank you. It's an honor to lead a very energetic group of passionate about improving the outcome of patients, and the support of the American College of Surgeons for the Committee on Trauma is tremendous and allows us to do all the work that we do.